Hello everyone and welcome to today's webinar titled Keynote Presentation, Choosing Wisely Lab Utilization First Steps, Addressing the Low-Hanging Fruit. This webinar is part of the Clinical Diagnostics and Research virtual event. And I'm Susie Valdez of Labroots, and I will be your moderator for today's event. Today's educational web seminar is presented by Labroots. So let's get started. Before we begin, I want to remind everyone that this event is interactive and we encourage you to participate by submitting as many questions as you'd like during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing this presentation, just click on that Ask a Question box located on the far left of your screen. And as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits tab located on the top right corner of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Jeannie, Callum, a professor of laboratory medicine and pathobiology at the University of Toronto and the director of laboratory utilization at Sunnybrook Health Sciences Centre in Toronto. For a complete biography of our speaker, please visit the biography tab at the top of your screen. Dr. Callum, welcome. You may now begin your presentation.
Okay, thanks, Susie, for that lovely introduction, and I'm excited to be here and to share all the efforts we've done at our center to try and improve our laboratory utilization. So just for disclosure, I am also a transfusion medicine researcher, and I do a lot of research to do with utilization of blood products and hence receive funding from numerous organizations. So I have 4 objectives for you today. First is to help you identify areas of inefficiency in the lab that need improving, to identify tests that are commonly overused that you might want to go after, and evaluate system changes necessary to bring that utilization down. And then lastly, how to assess how your system changes, were they successful or not, or were there any unintended consequences of those? The flow of this talk is going to go through first talking about strategies to figure out where you start your next or your first Choosing Wisely project. And then I'm going to talk about 3 quality improvement projects that we did at Sunnybrook. We've done many, but these 3 really highlight different strategies that you need to use depending on what the problem is. So I'm going to talk about how we reduced our AST and urea testing. And essentially, that project related to stopping the computer from ordering tests that the doctors weren't even ordering or wanted. Then I'm going to talk about stopping the CK use for cardiac injury. And for this, we had to convince the doctors that they didn't need it. They actually wanted it, but the system was also helping to order it. And then lastly, the B12, it was a completely different problem. The doctors were ordering duplicate tests because they couldn't see that the patient had a previous test. And so all these 3 things needed slightly different solutions, so I'm going to go through what we did for them. But before we go to that, let's talk about where you should start. So Choosing Wisely was started by the American Board of Internal Medicine and has been widely successful and duplicated across the whole planet. So you can see there we have Choosing Wisely Canada. Even within Canada, we have provinces that have their own special programs, but there's Choosing Wisely Australia, the UK, Europe, and so really everybody's jumped on this wagon. And the mission of all of these is to start conversations between patients and clinicians about what tests they actually need. And the mission of their organization is to choose care that's supported by the evidence. There's no duplication of tests. The testing doesn't result in unnecessary harm, and all the tests are truly necessary. The Choosing Wisely statements, a lot of people didn't like them because they all started with don't, but really it sends a message like, don't do this test in this situation. So some of the strategies that you might think about is, to get this going, is making sure that you've got the right team of people around you. You can't do this solely just with an intra-laboratory team. You need lots of team members outside on the clinical side. You need access to data, somebody to get that to you. And then you need somebody to analyze it. And I cannot stress the importance of having a professional statistician who can analyze your data and think about it differently than maybe you might think about it, and to generate really great run charts for you to be able to use for your presentations at your medical advisory committee, to your clinical teams, or when you publish your successes in a journal. You need the list of the Choosing Wisely lab-related items that have been put out by all these different organizations, so you can really run through them and think, I've already done that, we don't have to worry about this. Oh, but we haven't done anything about that. That's a big problem at my hospital. Let's focus on that. You need to look at publications of quality improvement projects for the laboratory from other centers, so you learn from their failures as well as their successes, because they might give you some ideas about how you might do it at your hospital. And then lastly, if you say you choose a test, say you're going to focus on vitamin B12 testing, you got to pull out all the guidelines and systematic reviews about that, so you're certain that you've got really solid evidence to convince your doctors that they can change their lab ordering practice. And then really lastly, to lead this, you've got to be super energetic. Everybody's going to come to you and say, oh, that's going to be a lot of work. That's not going to work here. I've got too many other things on my plate. But if you could provide a lot of energy, you're going to be able to convince people to do things they probably didn't think were possible. So just an example of getting the right team. This is the team we put together when we decided that we had to address the use of the AST test and the blood urea nitrogen test. And so we put together a big team. So I didn't have to do this all by myself. So I had a resident who did a lot of the background work on researching when these tests actually were necessary. I got a general internist who also has a laboratory appointment because he really understood how the lab worked and also how the clinicians were thinking. I got a general internist who is in charge of our information system for our electronic medical record because he understood how the computer thought and how we could manipulate the computer to get the ordering practice better. I involved the head of our Choosing Wisely program for our whole hospital, not just to do with the lab, but really the whole hospital to get her buy-in. And then we got a nephrologist because we needed that for the expert content knowledge for the urea, and then a gastroenterologist for the AST. We had a family physician because the family docs were ordering a lot of these tests unnecessarily, so he could do a lot of that education for me. And probably two of the most important people, we had an IT person from the lab to get us our data and to analyze it. And then we had a BSc student who did it as a research project, and she did all the grunt work for me of changing all the order sets and the computer order sets to make this happen. So you really need a big, big team. And you need access to data. And so we worked with our decision support at our hospital to generate just a little portal where we could go in and we could access the data and look at, ordering test volumes by doctor, by location, by groups of locations like inpatient, outpatient, to really help us figure out, okay, where do we need to start? And this little portal allows us to look at who's ordering the test. Most of the time, the doctors actually aren't ordering the tests. They're being ordered by order groups, order sets, but it really tells you who you need to go talk to figure out how does this test get ordered, because you're going to be pretty certain that it's actually not being ordered by the docs. And then by location, is it a whole hospital-wide problem that you have to address, or is it maybe just like 3 locations you got to focus on? And you need access to a statistician. I have an amazing statistician that does all of my blood-related research as well as my utilization research, but she looks at the data in ways that, I would never look at. And so on our most recent report that we got out on our B12 intervention study, she actually generated a Kaplan-Meier curve for the survival at my hospital without a repeat B12 level. And so that she looked at the data in ways I would never have looked at. And so I can't stress again the importance of having a statistician on your team. And I had my assistant comb through and cut and paste from every Choosing Wisely statement for every country that we could find it online, so that I had this long list of the test, which group was putting out the statement, and what was the fine print under that statement. So we could go back to our Choosing Wisely team and decide, okay, where do we start? Which ones have we done? Which ones we haven't done? And this gave me a really great starting point. So I think that this is kind of a great exercise as you go through your different projects. And then you got to look at the publications. You're not going to be able to do this without evidence. You know, when we went to look at fixing the vitamin D, you know, it was clear that vitamin D supplementation, let's like not even talk about testing yet, but just taking vitamin D supplements has really never been proved to change any outcome. And you can go to the systematic reviews and boy, that's surprising. It doesn't change fracture rates. It doesn't change mobility issues in elderly people. It doesn't change mortality, let alone does it change if you know what your vitamin D level is, if supplementation doesn't work in a population-based way. We do know that actually vitamin D is harmful because we know it causes kidney stones, but we can't find any clear benefit at a population level. So really important to go after the guidelines, but also at the same time, pull out the literature on quality improvement projects relating to vitamin D. So I've just pasted 3 different titles of people that have looked at vitamin D to try and control the use. And it's really important to read through those, really read the methods in depth to understand how they did it, because it's going to give you great ideas about how you're going to do it. Okay, and so at the end of that, you have to think, okay, where am I going to start? You know, are you going to start with just one test and really focus on one test? Or are you going to look at a group of tests? Are you going to look at the most expensive test because that's going to make your VP of Finance super happy? Are you going to look at send-outs? They tend to cost us a lot of money, and there's a lot more logistics of sending out samples. For us in Canada, we also have out-of-country tests. They cost us a lot of money, and it's even expensive just to ship the sample. Are you going to look at the frequency of repeat tests, like a test within a certain duration of a normal test result? Are you going to look at what the Ministry of Health, so in our country, we have the Ministry of Health that, kind of oversees how we're doing, and they're watching the laboratory tests that are being done at every hospital, and they put out a list of their kind of, urgent quality improvement projects they want us to get on. Are you going to look at efficiency, not just, utilization, but, can we get the tests out faster and turnarounds better? And then my biggest beef is paper. We use so much paper within many of our laboratories. This is just the back corner in our blood bank, and just the amount of paper that gets sent out for off-site storage for many years. And I think we also need to address this. There's lots of areas for utilization, not just test utilization, but also efficiencies, paper, etc. So as I said before, the Ministry of Health, this is the most recent list that was sent to us from a utilization point of view. And the Ministry of Health asked us, do you do any of these wrong things? And so when we looked at this list back in 2017, 4 of the 5 things that they asked us related to lab testing, and you can see there in the, the X with the green, we'd done one of them, we'd gotten rid of the folate testing. So we'd at least done one of the 4 lab ones, but the other 3 we'd continued to do. So we still, in the merge, even though we decoupled the INR and the PTT from ordering, they'd regroup them in the emergency department. So we're working on fixing this. We were still using the CK for diagnosis of a heart attack, and inpatients were generally getting daily laboratory tests. We've been working on this as well. We have, like, when you go to log in to our electronic medical record, for many months, there was this big banner to say, don't order more than 3 days in advance, trying to get people to just think short-term on their frequency of their laboratory testing. I think in the long run, we have to go to, you don't order tests for more than 1 day, but right now we're focusing on 3 days. Okay, and if all else fails and you can't figure out where you're going to start, really helpful to me is drinking a lot of coffee. I spend a lot of time in the coffee lineup talking to my clinicians, and they tell me, oh, Jeannie, you got to fix, we're ordering so many CRPs in our ICU, you need to fix this. Or we're doing too many ESRs or CKs in the CVICU. And so sitting down and chatting with them is super helpful in helping me kind of figure out where do we go next. Okay. Now I'm going to transition, and I'm going to talk about 3 analytes that we decided, 3 projects that we decided to focus on. So the first one was we decided to focus on the urea and the AST. And the reason for this is the urea was one of the most common tests after the CBC that was done at my hospital. So there's lots of room for improvement. not a single physician was putting up any roadblocks to change. They kept saying, oh my goodness, you need to fix this. Docs were stopping me in the hallway and saying, Jeannie, we're ordering way too many of these tests. Can't you somehow figure out how to get the computers to stop ordering these? And my nephrology and gastroenterology colleagues were more than willing to help me, as long as at the meetings I brought the coffee and they didn't have to do a lot of work. They just had to provide their expert input. And for these two analytes, most of the tests were not being ordered by the doctors. They were being ordered by the computer system in such a way that it was going to be easier to fix them. So the first thing that I did was I had my general internal resident come up with, by looking at the literature, when we thought it was appropriate to do an AST. Generally, as a single measure, you would never do an AST daily in a patient because an ALT is a much better reflection of liver injury. And then same thing for the urea. You know, these tests are still good tests when they're done in the right patient setting with the right frequency. You know, for example, the AST is used in looking at scoring systems for liver injury for hepatic fibrosis. It's done as a single test, a single ratio. You don't need this ratio done every day. And for urea, you know, for example, when you're on dialysis, the recommendations in the guidelines is that every 6 weeks you should have a urea clearance test. So the patients all get 2 ureas on the same day. But that should only be done once a month, once every 6 weeks. So there are isolated situations where you might do these. And then we use this to promote education. Education alone isn't going to change anything at your hospital, but it's kind of a core part of it. People need to understand why you're changing the rules. When they've always ordered an AST, an ALT, and an ALP, and a bilirubin all together, why'd you take one of them out? I just need to know why. The next thing we did was we looked at the data. So this is a total number of tests in 2017, and we looked at which doctor type was ordering the AST and the urea. And you can see there for the AST, which is really a test of the liver, you know, it should be mostly ordered by gastroenterologists, and not a single gastroenterologist came up on the top 15 list. So obviously right there's a problem. And you can see that the second most common person that was ordering the AST was the triage nurses. And that's really odd because you never need this test in the emergency department, except for in really unique situations. So obviously big room for improvement. Very similar findings for the urea. So the nurses in the eMERGE were ordering more than 75% of our urea tests. So you can see right there with just changing the order groups for the emergency nurses, this was going to be super easy to fix. For the urea, it looked a little bit more appropriate. You know, the nephrologists were coming up as the most common people ordering this, and that's their attending months on the dialysis unit. So there were some better things going on with the urea than the AST. And the next thing I had our statistician in R generate these great run charts. If you want to do run charts, you can do them in lots of different platforms, but R is probably one of the best platforms to do this. And we had this nice, no change, because of course we hadn't done anything about the urea, but we were running about 12,000 urea tests per month. And then we looked at our baseline for the AST. Again, we hadn't intervened, nothing had been changing, so we have this very flat line of about 3,200 tests per month. So we had a great run in to be able to show a change. So then we got to work. So after doing a very detailed analysis of how the test got ordered, we had to go after 4 different locations within our hospital ordering system to figure it out. So for inpatients, doctors could order tests on when they admitted a patient, say with COPD. They would have an order set. They could either do it in the computer system, or we had downtime paper order sets. And so we went through all of those order sets, and we had to change 41 of them to remove the AST and the BUN from all of those. From those order groups, a clerk would go in and enter the orders. They would go across to OASIS. In addition, the clerks and the nurses had their own personalized order groups they could have created 20 years ago that included the urea and the AST. and we sucked it out of their, first we sucked it out of their order groups, and then we decided at a later point, we just disabled them. You weren't allowed to generate your own personalized order groups because it just was an opportunity for people to generate bad practice that was very difficult later on to change. The next thing we had to do was figure out what to do with the triage nurses in the emergency department. What had been happening is the nurse would look at the patient and they would be presenting with chest pain. They would have a chest pain order group in our computer system. They would order it, and that would come across to our SunQuest lab system. And so we had to change all of those order groups for chest pain, GI bleeding, to take out the AST and the BUN. We actually took out other stuff while we were in there because we're like, oh my goodness, why are you doing that test too? So we didn't actually just change these two. We changed a whole bunch of other stuff to kind of give them a complete refresh, and then did a lot of education with the nurses in the emergency department, just so they understood why we were taking these tests out. In the outpatients, so these are like, patients that are at home and they come in to see their endocrinologist and then go to the lab. It's all done on paper, which is obviously a problem in itself that has to be fixed at some later point. But we removed these two tests, so they're not even listed. We're trying to push them into the back of the doctor's brain, so they actually had to write them out. And so when you asked for a liver profile, you just got the ALT and the ALP. And then lastly, in our cancer center was at least, electronically ordering this, so the doctors were ordering it. They also had their own personalized order groups that they could create. So if you were a medical oncologist that saw patients with liver cancer, you could have your AST and your urea in your order groups, but we pulled them out on block. And so there were something like 5,000 order groups over there in our cancer center for all our different doctors, and on a single day they all got pulled out. They could still order them, but the computer wouldn't order them. They had to actually think, and it came along obviously with a lot of education. And this is what happened. So you can see, because this was a systems problem, overnight you can make a change. And so we dropped from 1,200 tests per month to about 2,000 tests per month. And we're currently running about 13% of the time somebody sends a creatinine, they also send a urea. So lots of those are still appropriate. Some of them are done for research tests for clinical trials. Some of them are done for our urea clearance tests. So some of these are appropriate, but still there's probably a little bit of room for improvement there as well. And we had an equal amount of success for the AST. We're actually down to now only 7% of the time somebody orders an ALT, you get an AST. And so we've had really remarkable success of pushing this out of the doctor's brain and forcing them to do the right test. And we've had nice stability over a year after this time period. And don't just stop there. Publish your data, because other people can learn from you and learn from your successes and your failures. So we published this in BMJ Quality and Safety. And we also generated a banner that went on our, we're at Sunnybrook, so our internet's called SunnyNet. And we put a banner there to promote our success, so all the doctors knew that we were having really great success. So it starts almost like a little story, why you should think twice about before ordering these two tests. It tells you in 2016 in January, this is how many tests were done per month, what our goal was, why did we choose these two particular tests to work on, and then just a little timeline of like all the different things that we did to try and fix this problem, just a little bit of education. And then at the bottom of the banner, it was our success rate, that we got a 74% reduction combined for these two tests in the total amount of utilization. And a big thank you out to the clinical team for really supporting us in doing this initiative. Okay. So that was the really easy one. The second one was trying to get rid of the CK for cardiac injury. This was a much more than, it was partly a systems problem, but a lot of the doctors, particularly our cardiologists and some of our cardiac surgeons and cardiovascular intensivists, still loved this test. And so this created a little bit more work. Fortunately, I had Dr. Raza, who at the time was a general internal medicine resident who wanted to do general internal medicine, and he worked on this project, but by the time he finished, I'd converted him into understanding that hematology was the best subspecialty, and in July of next year, he will be one of our hematology residents. So we've gotten to this dotted line at Sunnywork. So originally, we had done a CK and a CKMB for cardiac injury, and then troponin came along, and we added the troponin without taking the other two away. We eventually were able to just stop offering the CKMB test, but they still kept ordering the CK. But we never went the final distance and went straight to just a troponin only. And so that was our challenge for this quality improvement project. So the first thing, like we did with the first project, is we looked at the data. So this is just for 1 month in September, and we looked at, how many doctors were ordering CK or troponin, and what the ratio was, and how often they were ordered together. So our CK to troponin ratio was running at about 88%. It was super high. We didn't really have a clue of where we needed to get this to, but we wanted to get it below 25%. And 78% of the time, these two tests were ordered together. So we were pretty certain that they were being ordered for cardiac injury when you really shouldn't be. And almost all the tests, or the bulk of them, were coming up with a normal test result as well. So probably some over-ordering going on. Just like we did for the AST and the urea, we also looked at, well, who were the top 30 doctors ordering this? And you can see there, it was really just very isolated parts of the hospital. So it was the patients in the emerge, the cardiovascular ICU, the ICU, and the cardiac ward. So we didn't have to go after the whole hospital to fix this problem. We really had 4 areas that we had to focus on. So compared to the urea and the AST, where it was the whole hospital we had to fix, this we could focus here. It wasn't being ordered by our family doctors or our outpatient internists. And so when we met with our cardiac and cardiac ICU team, they were like, no, we still need this test. We like this test for 6 reasons. We think it helps the assessment of that acute MI. We think it gives a more rapid diagnosis of myocardial infarction. It's better at diagnosing reinfarction after initial infarction. It's better at estimating the infarct size. So they wanted to look at the area under the curve of that CK over time and watch it, resolve to normal, and use that to estimate how much of the myocardium was injured. They thought it was a better test if you had an MI after a cardiac procedure like an angio. And if you had a subacute infarct, you had an infarct like several days ago, they thought it was better for detecting an old infarct. So it turned out that none of these 6 things that they believed in, they were all kind of fake news. So we really had to re-educate them to convince them that these were not true. And at the end of the day, they agreed that these were probably not good. But when I went to them to get their signature to pull the CK off of the order sets in the computer system for all the cardiac order sets, the answer was no, we still want this test. And we want it ordered by the computer on every single patient rather than picking and choosing which patients needed this. So at here, I kind of hit this roadblock. But fortunately, I had been in Norway and I was giving a debate. And I was giving a debate about one blood product over another with the U.S. military, which I'm happy to say I won. But during that, I had this great idea. And I thought, I'm going to challenge them to a debate. So I emailed my chief of cardiology and I said, well, let's do a debate. Since we can't get a final resolution, we're going to do a pro-CK versus con-CK for myocardial injury. I'll do the con. You need to get somebody on your team to step up to the plate to debate me. And 48 hours later, by the time I'd gone back from Norway, the papers were signed and they were on my desk. And we were able to pull the CK from all their order sets. So I'd never, ever actually had to do this debate. And so in this quality improvement project, we did almost the same thing once we got the approval to move forward and get them convinced of the need to do this. We obviously analyzed the data. We had wide stakeholder consultation. We removed the CK from every order group in the computer system, every order set. And then we did ongoing monthly analysis, so we knew, the cardiac ward, they're still ordering it. Why is that? And then, we found on our cardiac team that the clerks just had a little cue card which told them when this kind of patient was admitted, these are the tests they did, and the CK was still on that, even though we'd ordered it from the computerized order sets. And it worked. We're now sitting at about a third of the time they order troponin, we get a CK. We still have room for improvement, and we're still working on this, but we've made a major dent in the ordering of CK. And one of the ways I really like to look at these grouped together tests that you're trying to ungroup is start with one of these Venn diagrams. You can see there before, there was almost complete overlap between the troponin and the CK amount. And so in the post-intervention, I shrunk the CK, they're ordering less of them, but also less coupling of them. So I think it's a really good way in laboratory medicine to describe how we're using these two tests. Okay, we're just waiting for our code white to finish here. So the third test also had a completely, third project had a completely different problem. So we recruited Megan McLavish, who wanted to do a quality improvement project. She was another second-year internal medicine resident. One of the good things is the internal medicine residents have to do quality improvement projects during their training. So Paul Yip and I, who's our division lead for clinical chemistry, and I have been working with her to try and figure this out. And we actually harness the middleware to put controls on repeats, not just for the B12 that I'm going to show you here, but simultaneously for the hemoglobin A1C and the vitamin D. And so we were able to use the same technique to control multiple tests. And most of the problem that we found was that hospitalized patients were getting duplicate tests for B12 because the doctor couldn't see in the laboratory system that they'd already had that test 2 days ago and the test result was normal. And because they couldn't see it, they figured it had never been done, and so they ordered it again. And so when we looked at the B12 utilization baseline, we were running about 6,000 tests per year, of which about 8% were happening in the emergency department, 38% in the inpatient locations, and about half in the outpatient locations. In the outpatient locations, it took a long time, more than 6 months, before somebody had a repeat test. They were doing a much better job. But on the inpatient side, the median time to your next test was about 49 to 89 days. So it was really soon after their previous test. And so we calculated that by putting controls where you couldn't have a repeat test after a previously normal test within 12 weeks. And so we estimated that would yield us about 8.6% improvement in our performance. And so very similar to other projects, first we gathered information and data and had meetings with people that were ordering these 3 tests. We went to the medical advisory committee and we got them to approve us putting controls so they couldn't have a repeat test. So it was all done above board. It wasn't something sneaky we did in the background. And then Paul Yip worked tirelessly for several months to put in all the logic in the middleware to make this happen and do an extensive validation so we didn't mess up when we went live. And then we implemented the rules in early 2020. And so just for an example, Paul had to put 17 different conditions on this. So, for example, the computer had to look and say, okay, was there a previous result? Was it within the last 80 days? Instead of doing 90 days, we gave them a little bit of wiggle room, and then we said 80 days. Was the test result normal? And where for normal, we just, put that at 250, which most of us would agree is okay. We looked at the ordering location, making sure it's not being ordered by research. If for some research program, they need a B12 done on patients for, say, in the neurology research program, they're paying for it, they can still have it. And look for previous error flags. Maybe the previous result wasn't valid, and so they're reordering it to try and get a valid result. And so there were all these different conditions, so we made sure that we canceled the right test, but didn't cancel tests that actually need to be done. And then the physician in their electronic inbox, if they ordered a test within those 80 days, they get a nice little message: this test was not performed due to a previous order within the preceding 3 months. But you can contact the laboratory within 5 days. We still have the tube, and we'll run that test for you. I'm happy to report that basically nobody called the lab asking us to run these tests. And so people were, okay to go back and look and see, oh, there was a test. I can go look at a previous result. And then in addition to going to the medical advisory committee, a email message went out to all laboratory users, all the physicians, to say, hey, we've just put controls on the B12. We also did the controls on the vitamin D at the same time, also allowing no repeat tests within a certain interval, explaining why we did this, what the evidence for this is, and as far as I know, nobody complained. And so doctors are really generally buying into the fact that we have to use our healthcare resources more effectively. Otherwise, it's just going to cost so much money that lots of patients aren't going to get the care that they need. And here's the results. So this went live, as I said, in January of 2020. And you can see there the utilization went down. It went down for a very good reason, and that would be COVID, because lots of patients don't want to have any laboratory testing done. But you can see also there in that red color are all the canceled tests. So where we estimated that around 8% of tests would get canceled, we were pretty bang on at 7.5%. So despite COVID, we were pretty bang on what we were going to be able to achieve with these middleware controls. And you can see here on the pre-intervention to the post-intervention, and I'll remind you, I didn't have to do any of this analysis. I got my statistician to do it. If I had done this analysis, it would have taken me a week, whereas she could have done it in a day. So you can see there, of people that went on to have repeats, having a repeat within 3 months was about 50% of the repeats, versus we dropped that number to 9.5%, having a repeat within that time period. So a very effective intervention. You can also see that the median time to repeat went up dramatically. And we also, as a balancing measure, every time you do a quality improvement project, you want to think about, okay, what are the downsides? How can I cause harm by my intervention? And so two of the things that we wanted to look at was how many times did we run the test when we shouldn't have run the test? And that happened about 20 times. It's not so bad. But we had 3 tests that should have been run, but that weren't run, that we're still trying to figure out, why did the computer not run them? Because there was no good reason. So we're still monitoring this, but really crucial that you monitor this. The 20 that were run that shouldn't have been run, there were really good reasons for this. So we don't run a B12 on a Saturday or a Sunday. So if a doctor orders a B12 on a Saturday, and then they say, oh my goodness, there was no B12 result, I'll order it again on Sunday, well, it still won't get run on the Sunday. They'll both be put on the analyzer to be run on the Monday, but because they're being run simultaneously, there is no valid result, and both of them will come across and be run at the same time. So as you build your middleware rules for this, really think really carefully of all the possible permutations and combinations that could go wrong so that this doesn't happen. In addition, monitor for it so you can sort of slowly tweak your rules until they're just perfect. Okay, so now I'd like to just review those objectives that we had and really summarize what I've talked about. So the first thing is to identify areas of inefficiency in your lab that need improving. So really important to look at your data, talk to your clinicians, find out what they think is an overused test at your hospital, and look at all your different processes and find out what are the things that you could harness to make change. How do you order your tests? Do you have computerized physician order entry? Do clinicians have their own order groups that you could modify? How would you actually be able to harness to generate change? Identifying the tests that are commonly overused at your organization. So look through that choosing wisely list of all the different lab tests that people are trying to fix. Look at the guidelines. Where's the evidence for the the best evidence to cut out a test, and really there's a lot of evidence for that vitamin D test, the CK, the AST, the urea. And sifts through different papers. A lot of people have published their successes in their quality improvement projects for laboratory testing. Even if that test wasn't the test you're going to work on, I bet you a lot of their methodology and how they did it you can learn from. You want to evaluate the system changes necessary to bring your utilization down, and so that the computer order tests that are ordered by the computer versus being ordered by the doctors. Which ones the doctors are ordering? How much education are you going to need to do to get them to change their practice? And how much of your problem is duplicate tests? Tests that are being run because the doctor actually can't see somehow in the lab system that that test's already been done. And then assessing how you know if your system change has been successful. So somehow figure out how to get easy access to monthly data. And again, I can't stress how important it is to find a statistician that's going to work with you to help generate your run charts, analyze your data, help you think about how your data is going to be presented in your papers and in your presentations to your hospital, your clinicians, your medical advisory committee. So with that, I'll stop, and I'm happy to take questions and comments, criticisms. Thank you.
And thank you, Dr. Callum, for that informative presentation. We will now start the Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. We already have some great questions coming in. Our first question, Dr. Callum, is what laboratory inefficiency issues and problems do you find most of? And what problems would you say are most important and a priority to solve first?
Yeah, so I don't think there's a one good answer for everybody, and every hospital is going to have a different setup. So I can tell you, when I think about my lab now in terms of where we've gotten to, we sort of fixed all the low-hanging fruit, and one of my biggest pushes right now for me is to get rid of the paper. Because to me, the paper is inefficient. It creates extra workload for the clinicians. And so we're working on that. But that's because I'm at a different point. I've already fixed some of the other things. So I think you need to look at your own statistics. You got to look at your own processes and figure out what's your top thing. Don't try and start 14 different projects at the same time. Just start 1, 2, get them done, reevaluate them, and move on to the next project.
Thank you so much. That sounds like good advice for everybody. Our next question, does the Choosing Wisely initiative offer specific guidelines and recommendations to reduce unnecessary expenses related to the reduction in length of hospital stay and also inappropriate utilization of high-cost medications?
Yeah, so if you look at the Choosing Wisely recommendations, they don't have a lot of verbiage there, but there is quite a concise paragraph on, say, say for blood transfusion, you should not be ordering more than 1 red cell at a time, and it gives a justification as well as some key guideline references. So you have a really good starting point for where to start. In terms of, unnecessary expenses related to reduction in length of hospital stay, there actually aren't a lot of studies that show that by these quality improvement projects we can reduce the length of stay. There have been a few studies, say, for example, if you get less blood transfusions, you stay less, a day or a half a day length of stay drops. Or if you don't do a CK test as your routine for myocardial injury, you stop patients from having unnecessary angiograms because they actually don't have cardiac injury, and so they go on to have an angio, and they end up with complications of that, and obviously a normal angio result, which we really shouldn't be finding.
Thank you so much, Dr. Callum. I want to thank our audience members for these great questions. We have one more question coming in. Relating to blood transfusion, how can hospitals and nursing utilize IT-enabled strategies to decrease the number of routine two-unit transfusions to guide providers to order appropriately?
So across Canada, actually, we've started a campaign which is titled "Why Give Two When One Will Do" for the red cell transfusion. And so this habit, which is not based on any evidence, every single clinical trial that's been published since 1999 promoted single unit red cell transfusions. And despite that, when we started our Choosing Wisely, Why Give Two When One Will Do, 65% of transfusions across Canada were happening as these double unit transfusions. And so across our country, we have put out a toolkit on how to address that specific problem. The way that we did it at our hospital is all of our order sets default to a single unit. So you actually have to go in and change it to 2 units. And I'm only talking about inpatients. The way we transfuse outpatients, they often get 2 units at a time because we want them to come only once a month or once every 2 weeks. So we're really just talking about the inpatients. And in addition to pushing them in the right direction with our computerized physician order entry, we also have our laboratory technologists screen every order for an inpatient. If they ask for 2 and the patient's not bleeding, they get told, I'm sorry, that's outside the guidelines. We can give you 1 unit, and if you repeat the hemoglobin, if you still need a transfusion based on your laboratory test results and your clinical assessment of the patient, then you can go on to have the next unit. When we implemented that at Sunnybrook, we did that in about 2008, so quite a long time ago. We went from using 18,000 red cells per year at Sunnybrook to 10,000. It is probably one of the most expensive bad practices that you can possibly have. Ari Shander, who's done a lot of economic analysis of the cost of blood transfusion, estimates that transfusion costs, the system back in 2010 dollars was about $741 per unit transfused, which is a remarkable expense. It probably costs close to $1,000 per patient today. And so there's a lot of room to improve on that. You'll also look out for, we have a publication coming out. We just did a multi-center trial where we had hospitals across the country start screening, having the tech screen for things like single unit red cell transfusions and appropriate thresholds. And we were able to reduce the threshold for transfusion, improve the appropriateness, cut down to single unit transfusions, and we saved about 5,000 red cells at 13 hospitals over a 10-month period. And we were able to track mortality and length of stay, and there was absolutely no harm from the result of removing a lot of red cells from those hospitals. And so I think there's big room for improvement in your transfusion practice.
Thank you so much, Dr. Callum. We have time for one more question. How can one support and get involved with Choosing Wisely?
Yeah, so I guess there's you can get involved at your local hospital level. And so I would find out at your local hospital level, do you have a Choosing Wisely committee? Do you have a laboratory utilization committee? And if you don't, maybe this is your opportunity to start one. At the national level, many countries have Choosing Wisely programs across the country, and you can get involved in across different jurisdictions. And then at the national level, there are committees looking at trying to push utilization forward. Even at our University of Toronto recently, they started a laboratory utilization committee across the whole 7 hospitals that we have at the University of Toronto to try and learn from each other so we don't kind of repeat, the failures of other people, and we learn from other people's successes. It's also really important if I'll be swimming upstream, say I'm trying to get rid of the CK at my hospital, but every other hospital within Toronto is still pushing that the CK is the right test. The residents are getting one message from one hospital versus a different message from my hospital, it's certainly going to help me be more successful with my intervention if everybody in my region is singing from the same song sheet.
Thank you so much. And I want to thank you for your time today and for your important research. Would you like to provide our audience members with some final closing remarks before we go?
For sure. So one, I just want to thank you for giving me the opportunity to share what we've done at Sunnybrook. I hope you've sort of thought about how you're going to figure out where to start your next Choosing Wisely project. And honestly, the best place to start is sit down with some of your clinicians at your hospital that are really enthused about fixing this. Sit down and have coffee with them. Sit down with them and look at the data with them and look at those Choosing Wisely lists from the American Board of Internal Medicine or whatever country that you're in to figure out where you're going to start. Look at your processes. Choose something that's going to be super easy. Choose one of the ones that we did, the AST, the urea, the CK, the B12, the vitamin D, the hemoglobin A1C. These are really easy wins. And just choose one or two. Don't choose like so many projects, you're never going to get them completed. And get yourself a statistician to help you analyze that data. And make sure you publish your results, present them at national or international meetings so that, one, we get more enthused by your successes and we learn from you, and globally across the planet, we're going to reduce our utilization and really harness a major paradigm shift in the way that we provide healthcare.
Dr. Callum, thank you again for your presentation and for your important research. And before we go, I want to thank our audience for joining us today and for their interesting questions and questions we did not have time for today. And those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand for 6 months till May of 2021. Labroots will alert you via email when it's available for replay. We encourage you to share this email with your colleagues who may have missed today's live event. Until next time, take care, stay safe, and stay healthy. Bye-bye, everyone.